Every minute, 1.9 million brain cells die. That is not a metaphor. That is not a dramatic statistic chosen to frighten you. That is what is happening inside someone's brain right now while they are sitting in their recliner and you are standing there wondering whether to call for help or wait a little longer to see if they feel better. Every single minute. A landmark study published in the journal Stroke calculated this number precisely. 1.9 million neurons destroyed per minute. 14 billion synapses severed every 60 seconds. The ischemic brain ages 3.6 years for every hour it goes without treatment. Think about that. In the time it takes to drive to the emergency room, debate whether it's serious enough, wait for a family member to come over, or try to search symptoms on a phone, the person you love can lose years of brain function that will never come back. That is why what I am about to share with you today is not just information. It is the difference between walking out of the hospital with the person you love or sitting across from a doctor who is explaining permanent disability. I'm Dr. Daniel Hayes, and today I'm walking you through 6 critical things to do, step by step, in the exact right order, if you believe a senior near you is having a stroke. This is not a general overview. This is a precise, research-backed action protocol built on the same science that emergency physicians use. By the end of this video, you will know exactly what to do, what not to do, what to say, and what to watch for before the ambulance ever arrives. Before we go into the 6 things, I need to give you one piece of foundational knowledge, because without it, the 6 steps won't make complete sense. Why strokes are different in seniors. A stroke happens when blood supply to part of the brain is suddenly cut off. In an ischemic stroke, which accounts for about 87% of all strokes, a clot blocks a blood vessel feeding the brain. In a hemorrhagic stroke, a blood vessel ruptures and bleeds into brain tissue. In both cases, the result is the same. Brain tissue begins dying within minutes. But here is what most people don't know about strokes in older adults specifically. After age 65, the brain has already experienced years of small, invisible changes. Blood vessels are stiffer. Circulation to certain regions is already less efficient. The brain's ability to compensate for sudden oxygen loss is reduced. That means a stroke that might cause mild symptoms in a younger adult can cause catastrophic damage in a senior. There is also something called a silent TIA, a transient ischemic attack, sometimes called a mini-stroke. It produces symptoms that last only minutes or hours, then seem to disappear completely. Many seniors and their families dismiss this. They wait, they assume it passed. But research is unambiguous. A TIA is a warning shot. Within 48 hours of a TIA, the risk of a full stroke spikes dramatically. Ignoring it is one of the most dangerous things a person can do. So when you are watching a senior, even if their symptoms seem to be getting better on their own, do not wait. What I am about to walk you through applies to both a suspected stroke and a suspected TIA. The action is the same. The urgency is the same. Now let's walk through the 6 things, in order, without skipping a single one. Number 1. Recognize the warning signs immediately using Be Fast. You cannot act on something you don't recognize. And stroke has a tricky quality. It does not always look the way people expect. The acronym most people know is FAST, which stands for face drooping, arm weakness, speech difficulty, and time to call 911. FAST was developed based on the Cincinnati Pre-Hospital Stroke Scale and has been used in public awareness campaigns for decades. But neurologists now use an expanded version called Be Fast, which captures a broader range of stroke presentations, particularly the ones that are easiest to miss. Here is what each letter means. B is for balance. Sudden, unexplained loss of balance or coordination. The person may stumble, lean to one side, or feel like the floor is shifting under them. They may grab a wall or chair with no explanation for why their legs are not working properly. This is not dizziness from standing up too fast. This is the sudden, new kind, the kind that comes out of nowhere. E is for eyes. Sudden vision changes in one or both eyes. This can mean blurry vision, double vision, or a complete loss of vision in one eye. The person may say things look strange, or cover one eye, or squint in confusion. This symptom is often missed entirely because people attribute it to tired eyes or a headache. F is for face. Ask the person to smile. Look at their face carefully. Is one side of the smile drooping downward? Is one corner of the mouth pulling down while the other is normal? Facial asymmetry that appears suddenly, especially when the face looked normal just moments before, is a significant warning sign. A is for arms. Ask the person to raise both arms in front of them and hold them up. Watch for 30 seconds. Does one arm drift downward? Does one arm feel weak or numb? The person may tell you one arm feels heavy or that they cannot grip anything with one hand. Sometimes they are not even aware of the weakness. S is for speech. Listen carefully. Is the person slurring words? Are they using wrong words without realizing it? Are they struggling to find words, pausing mid-sentence, or unable to repeat a simple phrase clearly? Speech difficulty in stroke is not gradual, it is sudden, and it is often more frightening for the person experiencing it than they let on. T is for time. This is the action step. The moment you notice any one of these signs, time has started. Not later, now. One critical point here. Stroke symptoms do not have to be dramatic. A senior with a stroke may not fall dramatically or cry out in pain. They may simply look confused. They may go quiet when they are usually talkative. They may seem to be staring. They may say their arm feels strange. They may try to stand and stumble for the first time in years. Trust the sudden change. Sudden is the word that matters most. If something is different in a way that cannot be explained and it happened quickly, that is your signal to act. Number 2, do not give food, water, or medication. This one is critical, and it is the one that well-meaning family members most often get wrong. When a person is having a stroke, the muscles involved in swallowing are frequently affected. The technical term is dysphagia, difficulty swallowing. The nerves that control the throat and the back of the tongue are fed by the same blood vessels in the brain that a stroke disrupts. A person who is mid-stroke may appear alert enough to drink water. They may ask for water. They may say they are fine and reach for something to drink. But their swallowing reflex may be partially or completely impaired without them, or you, realizing it. If you give them water or food at this moment, that liquid or food goes into the airway. It travels toward the lungs. This is called aspiration. Aspiration during a stroke causes aspiration pneumonia, a severe lung infection that significantly worsens outcomes and can be fatal. The same rule applies to medication. Do not give aspirin, not yet. I know this feels counterintuitive because aspirin is commonly associated with heart emergencies. But strokes fall into 2 categories, ischemic and hemorrhagic. An ischemic stroke is caused by a clot. A hemorrhagic stroke is caused by a bleed. Aspirin thins the blood. If the stroke is hemorrhagic, giving aspirin makes the bleeding worse. You cannot determine which type of stroke is happening without a brain scan. Only a hospital can determine that. Until then, no medication, nothing by mouth, not water, not food, not pills. This rule does not have exceptions. Number 3, call emergency services immediately. Do not drive. Pick up the phone. Call 911 now. Do not debate this. Do not decide to drive to the hospital yourself. Do not call the doctor's office and wait for a callback. Do not wait to see if symptoms improve. Call emergency services immediately. Here is why calling 911 instead of driving is not just a preference. It is a clinical decision that changes outcomes. When an ambulance is dispatched for a suspected stroke, the paramedics alert the receiving hospital before they arrive. This matters enormously. Stroke centers have what is called a stroke team, a coordinated group of neurologists, radiologists, and emergency physicians who can be mobilized in advance. When the ambulance radios ahead, the CT scanner is cleared. The stroke team is already assembling. The medication is being prepared. The moment the patient walks through the door, assessment can begin within minutes rather than the patient waiting through triage, paperwork, and intake. Research published by the American Heart Association is explicit on this point. Pre-hospital notification by emergency medical services dramatically reduces door-to-treatment time in acute stroke care. And every minute that treatment is delayed, brain tissue is dying. There is also a safety dimension. A senior having a stroke in a car is a serious risk. Loss of consciousness, seizure, or sudden deterioration can happen at any moment. Paramedics are trained to manage exactly these situations while in transit. They can initiate monitoring, maintain airway, and communicate with the hospital. You cannot do any of that while driving through traffic. When you call 911, say these exact words. I believe someone is having a stroke. I need an ambulance immediately. Then give your address clearly and stay on the line. The dispatcher will guide you. Follow their instructions precisely. Do not hang up until the ambulance arrives. Number 4, note the exact time symptoms started. This step takes seconds. It costs you nothing, and it could save the person's brain. Write down the exact time you first noticed something was wrong. Look at a clock. Check your phone. Look at the timestamp on any message you received around that moment. Then keep that time. Write it on your hand if you have to. Do not let it slip away. Here is why this information is so powerful. The primary treatment for ischemic stroke is a medication called TPA, tissue plasminogen activator. It is a clot-dissolving drug that can restore blood flow to the blocked brain area if administered in time. Research has established that TPA is most effective when given within 3 hours of stroke onset. In some cases, the treatment window extends to 4.5 hours. Beyond that, the risk of the treatment causing bleeding in the brain outweighs the benefit. When the emergency team asks when symptoms started, they are not asking for a general idea. They need a precise time to calculate whether TPA is still safe and effective to administer. If you cannot give them a clear time, the physicians face a critical problem. They must work backward. If the last known time the person was normal was 8 hours ago, when they went to sleep, and they woke up with stroke symptoms, the treatment window may already be closed. This is why patients who wake up with stroke symptoms are in a particularly difficult category. Physicians cannot know exactly when the stroke began, but if you were with the person, you know. You saw them speaking normally at 7:42 in the evening. At 7:56, their speech became slurred. That 14-minute window matters. It can change everything about what treatments are available. Do not estimate, do not approximate. Do not say about an hour ago. Get the exact time, or as close to exact as you can, and protect that information as carefully as you would a phone number you cannot lose. Number 5. Keep the person calm, still, and positioned correctly. After you have called 911, while you are waiting for the ambulance, your job becomes very specific. You are not a physician. You are not going to treat the stroke. But what you do in the next several minutes can absolutely affect outcomes. First, keep the person as calm as possible. Emotional distress and agitation raise blood pressure. Elevated blood pressure during a stroke, particularly a hemorrhagic stroke, increases the rate of bleeding. Even in ischemic stroke, spikes in blood pressure can worsen the area of damage. Your voice, your manner, your presence, all of it matters. Speak slowly. Speak clearly. Tell them help is on the way. Tell them they are not alone. Do not panic visibly in front of them. Their brain is already under enormous stress. Your calm is medicine. Second, position them correctly. If the person is conscious and can sit or lie down comfortably, lay them on their back with their head and shoulders slightly elevated, approximately 30 degrees. This position supports blood flow to the brain without causing the person to be completely flat, which can increase intracranial pressure. Do not leave them sitting upright in a chair unassisted. A person mid-stroke can lose muscle tone suddenly and fall. Remove that risk. Guide them to the floor or a firm, flat surface gently if a bed is not immediately available. If the person is unconscious but breathing, place them in the recovery position. Roll them gently onto their side. This keeps the airway open and prevents aspiration if they vomit. This is a real concern during stroke, and the recovery position addresses it directly. If the person stops breathing and has no pulse, this becomes a cardiac emergency. Begin CPR immediately and tell the 911 dispatcher. Stroke can trigger cardiac arrest, and CPR is appropriate when breathing and circulation have stopped. Third, loosen any constricting clothing. A collar button, a tight necklace, anything pressing against the neck or chest. Circulation must not be restricted in any way during these minutes. Fourth, keep them warm but not hot. Do not apply heating pads or blankets that could raise core temperature. Research has shown that elevated body temperature during stroke accelerates brain cell death. Comfortable room temperature is ideal. And critically, do not let them fall asleep or lose consciousness without you noticing. Monitor their responsiveness actively. Talk to them. Ask simple questions. If they stop responding to your voice, report this immediately to the 911 dispatcher. Number 6. Gather the information the medical team will need. While you are waiting for the ambulance or riding with the patient, there are 4 pieces of information that the emergency team will need immediately. This information directly affects every clinical decision they make in the first 30 minutes. The first is the list of all medications the person is currently taking. This is more important than most people realize. If the person is on blood thinners like warfarin, rivaroxaban, or apixaban, the treatment approach for their stroke changes. Anticoagulants already present in the body affect whether TPA can be administered and at what dose. The emergency physician needs to know this before they administer anything. If you have time, grab the medication bottles, all of them. Put them in a bag and bring them. If you cannot do that, write down the names and doses as quickly as you can. If you know nothing else, at minimum, remember whether the person takes a blood thinner. The second piece of information is the person's history of diabetes. Blood glucose levels matter in stroke care. Very low blood sugar, called hypoglycemia, can mimic stroke symptoms exactly. Very high blood sugar worsens stroke outcomes and can affect treatment decisions. The emergency team will test blood glucose immediately, but knowing whether the person is diabetic helps them interpret results faster. The third piece of information is any recent illness, surgery, or trauma. A person who had surgery within the last 2 to 3 weeks may not be eligible for TPA because of bleeding risk. A recent fall or head injury changes the hemorrhagic stroke picture entirely. This history may not be in any medical record the emergency team can immediately access. You may be the only person who knows it. The fourth piece of information is the name of the person's primary care physician or specialist and the hospital or clinic where they receive their care. This gives the emergency team a fast route to relevant medical history. It tells them where prior brain imaging might exist for comparison. It connects the treating physician to the person's full medical story, not just the crisis in front of them. You may feel overwhelmed. You may feel scared. That is completely normal. But try to hold these 4 things in mind: the medication list, the diabetes history, any recent procedures or injuries, and the name of the doctor. These 4 items give the emergency team a clinical foundation from which to make faster, better decisions for the person you love. One more thing you must know: the TIA that looks like recovery. I want to come back to something I mentioned at the beginning, because it is responsible for preventable tragedy in seniors more often than almost any other mistake families make. A transient ischemic attack produces stroke symptoms that resolve on their own within minutes to hours. The person's speech returns, their arm strength comes back, their face looks normal again. They may even feel completely fine, and the family exhales. Everyone relaxes. The consensus around the kitchen table is that it passed. It was nothing, maybe low blood sugar, maybe fatigue. The research is unambiguous about what happens next. A TIA is not a minor event that resolves. It is a neurological emergency that has temporarily resolved. The blood vessel that was blocked still has the conditions that caused the blockage. The clot risk is still present. The artery is still vulnerable. And within the next 48 hours, the probability of a full, devastating stroke is significantly elevated. If you witness stroke-like symptoms in a senior that seem to improve or resolve, call 911 anyway. The emergency team will assess whether a TIA occurred. They will order the imaging needed to determine what is happening in the brain and the blood vessels feeding it. They will initiate the medical management that reduces the risk of a full stroke in the hours and days that follow. Never decide at home that the moment is past. That decision belongs to a physician with imaging equipment, not to a family standing in a kitchen relieved that grandma is smiling again. The smile can disappear in 60 seconds with no warning and not come back. The real cost of waiting. I want to leave you with a number that I carry with me. A typical stroke, untreated, destroys the equivalent of 3.6 years of normal brain aging every single hour. That means a person who waits 4 hours before reaching a hospital has lost, in terms of brain function, the equivalent of almost 15 years of aging in 4 hours. While people were debating whether it was serious enough to call an ambulance, every single one of the 6 steps I have walked you through today is about one thing: reducing the distance between the moment symptoms begin and the moment trained physicians begin treatment. Recognize using "be fast." Give nothing by mouth. Call 911, not a car. Note the exact time. Keep them calm, still, and positioned correctly. Gather the medical information. 6 things, in order, without hesitation. The person sitting across from you at dinner tonight, the parent, the grandparent, the spouse who has been your partner for 40 years. They deserve every one of those 1.9 million neurons per minute that your fast action can save. Now you know what to do. Print this list if you have to. Put it on the refrigerator. Share this video with your family. Because the stroke does not announce itself in advance. It arrives without warning, and it does not wait for you to feel ready. You are ready now.